Section 5. Respiratory System. Outline. Introduction. 5.1. Respiratory Tract. Structure and Functions. 5.2. Pulmonary Ventilation. 5.3. Pulmonary Circulation. 5.4. Pulmonary Diffusion. 5.5. Transport of gases. 5.6. Regulation of respiration. 5.7. Respiration. Applied aspects. Introduction. The word respiration has been derived from the Latin word respirare, which means to breathe. The primary role of the respiratory system is to provide O2 to the tissues for metabolic needs and remove the CO2 formed by them. An adult body consumes about 250 milliliters of O2 and produces about 200 milliliters of CO2 per minute. Respiration entails two processes: the external respiration and internal respiration. The internal respiration or tissue respiration refers to utilization of O2 and production of CO2 by the tissue. It is generally considered the domain of biochemistry. The external respiration includes supply of O2 to the tissues from the environment and excretion of CO2 released by the tissues into the atmosphere. The process of external respiration involves three major events. Pulmonary ventilation, i.e., exchange of gases between the environment and lungs. It includes mechanics of respiration. Pulmonary diffusion refers to transfer of gases from alveoli to the blood by diffusion across the respiratory membrane. To understand the process of pulmonary diffusion, it is essential to understand facts about pulmonary circulation and the properties of gases and the laws governing diffusion of gases. Transport of gases from the blood to the body cells and back. The respiratory adjustments in health and diseases are essential for life. And to understand these, knowledge about regulation of respiration is must. The study of respiration without the concepts about functional anatomy of the respiratory system will not be easy, and so has been discussed in the very first chapter of this section. Chapter 5.1. Respiratory Tract. Structure and Functions. Functional Anatomy. Respiratory Passages. Respiratory Parenchyma. Microscopic structure of alveolus. Respiratory membrane. Blood supply. Innervation. Functions of respiratory system. Respiratory functions. Non-respiratory functions. Functions of defense mechanism. Functions of pulmonary circulation. Metabolic functions. Functions of respiratory muscles. Functional anatomy. The chief organs of the respiratory system are right and left lungs. The oxygen contained in the atmospheric air reaches the lungs by passing through a series of respiratory passages which also serve for removal of CO2 from the alveoli to the atmosphere. The respiratory system also includes a pump that ventilates the lung. This pump consists of the chest wall and respiratory muscles. Salient points about functional anatomy of respiratory passages and lungs are discussed here. Functional anatomy of chest wall and respiratory muscles is discussed in Chapter 5.2 on pulmonary ventilation, which includes the mechanics of respiration. Respiratory passages. Respiratory passages include the following structures: Fig. 5.1-1. Figure 5.1-1 The air passages. 1. Nasal cavities. The air enters the body through right and left anterior, external nares which open into the right and left nasal cavities. Through the posterior, internal nares, the nasal cavities open into the pharynx. The nasal cavities warm up the air to the body temperature, humidify the air to 100% saturation, clean and filter the air of its particulate content by channeling the air through a tortuous path between the turbinates. The particles are deposited at the bends where they adhere to the mucus layering the nasal cavity. 2. Pharynx. From above downwards, the pharynx is divided into nasopharynx, oropharynx and laryngopharynx. Air from nasal cavities enters the nasopharynx and passes down through the oropharynx and laryngopharynx to larynx. From the mouth, the air can directly pass to oropharynx. 3. Larynx. It is continuous above with laryngopharynx and below with trachea. The air passes through the glottis, the triangular space between vocal cords, into the trachea. Apart from being a respiratory passage, the larynx also acts as a voice box. 4. Tracheobronchial tree. The air passages between trachea and alveoli divide 23 times to form the extensive tracheobronchial tree, Fig. 5.1-2. These multiple divisions greatly increase the total cross-sectional area of the airway from 2.5 square centimeters in the trachea to 11,800 square centimeters in the alveoli. Consequently, the velocity of airflow in the small airway declines to very low values. The 23 generation divisions of tracheobronchial tree have been numbered as Figure 5.1-2 The tracheobronchial tree. The trachea is designated as generation 0. The principal bronchi right and left, which are two major divisions of trachea, constitute the first generation. Lobar bronchi, which are division of the principal bronchus, form the second generation. Segmental bronchi, which are further division of each lobar bronchus, forms the third generation. Each segmental bronchus divides into several generations of branches that ultimately end in very small tubes called bronchioles. Terminal bronchioles is the name given to 16th generation of the divisions. Up to this generation of division, no exchange of gases is possible. Respiratory bronchiole is the name given to 17th 22nd generation of divisions. These are labeled as respiratory bronchioles because some exchange of gases is possible in these tubes. Alveolar ducts and in the alveoli or the alveolar sacs, which form the 23rd generation division. It is here that most of the O2 and CO2 exchange occurs. Thus, from the functional point of view, the tracheobronchial tree can be divided into two major zones. I. Conducting zone of the air passages is formed by the first 16 generations of passages, and it only transports gases from and to the exterior. Thus, conducting zone starts from trachea and extends up to terminal bronchioles. Since no exchange of gases is possible here, so starting from nose to the terminal bronchioles forms the so-called dead space, which has a total capacity of approximately 150 milliliters. II. Respiratory zone. The remaining 7 generations of the tracheobronchial tree, which includes the respiratory bronchioles, alveolar ducts and alveoli, form the respiratory zone, where exchange of gases occurs. Its volume is approximately 4 L. Histological features of the tracheobronchial tree. Histological features of the tracheobronchial tree. 1. Cartilaginous rings. Are present in trachea and initial bronchi a few generations. These are absent in terminal bronchioles and respiratory bronchioles. The cartilaginous rings of trachea are incomplete on their posterior aspect. This allows some contraction of trachea, but tracheal lumen cannot be completely obliterated easily. 2. Smooth muscles. Ends of cartilaginous rings of trachea are approximated by transverse smooth muscle fibers. In bronchi, bands of fibers tend to become circular, so that in terminal bronchioles they are present in large amount and form a sphincter. Smooth muscles are not present in alveoli. 3. Epithelial lining. In trachea and large bronchi is columnar and becomes cuboidal in bronchioles and simple squamous in alveoli. The epithelial cells of the tracheobronchial tree are ciliated. Cilia are absent in alveoli. Efficiency of ciliated cells of trachea and bronchi in propelling mucus and waste products is of higher order. Cilia are not influenced by nerve impulses. The mucus-secreting goblet cells and deep serous glands are present in trachea and bronchi, but are absent in bronchioles and alveoli. Fig. 5.1-3. Figure 5.1-3 HISTOLOGICAL features of epithelial lining of tracheobronchial tree. Respiratory parenchyma. Each respiratory unit consists of one respiratory bronchiole, which opens into a number of alveolar ducts, and each alveolar duct in turn opens into a number of alveoli. The 2 lungs contain about 300 million alveoli. Each alveolus has a diameter of about 0.2 micrometers. The alveoli are surrounded by pulmonary capillaries. The total area of the alveolar walls in contact with capillaries in both the lungs is about 70 square meters. Microscopic structure of alveolus, Fig. 5.1-4. Each alveolus is lined by 2 types of epithelial cells. Type 1 cells are flat cells with large cytoplasmic extensions and are the primary lining cells. Type 2 cells, granular pneumocytes, are thicker and contain numerous lamellar inclusion bodies. These cells secrete surfactant. Figure 5.1-4 MICROSCOPIC structure of alveolus. The alveolar wall also contains other special type of epithelial cells. Pulmonary alveolar macrophages PAM, which are active phagocytic cells. Lymphocytes. Plasma cells which form and secrete immunoglobulins. Amine precursor uptake and decarboxylation APUD. Cells which store and secrete many biologically active peptidases, e.g. vasoactive intestinal peptide VIP, and substance P, etc. Mast cells which contain heparin, various lipids, histamine and various proteases that participate in allergic reactions. Communication between the 2 alveoli occurs through small pores called pores of Kohn. Respiratory membrane. It is the name given to the tissues which separate the capillary blood from the alveolar air. It is important to understand the structure of a respiratory membrane for better understanding a diffusion of gases between alveoli and capillary blood, so it is described in detail in Chapter 5.4 on pulmonary diffusion, page 418. Blood supply. Conducting airway is supplied by systemic blood, whereas the respiratory zone of the lung is supplied by deoxygenated, venous blood coming through pulmonary arteries to lungs. Blood is oxygenated in lungs and is returned to left atrium via pulmonary veins. Innervation. The walls of bronchi and bronchioles are innervated by the autonomic nervous system. Parasympathetic fibers innervate through vagus nerve. Their stimulation causes cholinergic discharge, producing bronchoconstriction and increased bronchial secretion via muscarinic receptors. Sympathetic nerve supplying the lungs when stimulated causes bronchodilation and decreased bronchial secretion via adrenergic receptors, predominantly by beta-2 receptors, while alpha-1 adrenergic receptors inhibit bronchial secretions. Afferents from the lungs pass through vagus nerves. Functions of the respiratory system. Respiratory functions. The main function of the respiratory system in general and lung in particular is exchange of gases between atmosphere and blood. Non-respiratory functions. Besides the respiratory functions, the respiratory system performs many important non-respiratory functions, which include a. Functions subserved by lung defense mechanisms. Epithelial cells in the mucosal lining of the conducting zone secrete various molecules that are involved in lung defense mechanism. These include secretory immunoglobulins, IgA, colectins, surfactant proteins, SPA, and SPD, defensins, chemokines, cytokines, etc. 1. Immunoglobulin IgA is secreted in the bronchial secretion and protects against respiratory infections. Ciliary escalator action is an important defense system against airborne infection. The dust particles in the inhaled air are often laden with bacteria. While passing through the repeatedly branched bronchial tree, the dust particles and the bacteria are caught in the mucus layer present at the mucosal surface of respiratory passages and are moved up towards pharynx by the rhythmic upward beating action of cilia. Fig. 5.1-5 and swallowed. Cigarette smoke disturbs the ciliary function. That explains the higher incidence of respiratory infections in smokers than in non-smokers. Applied aspects. Cystic fibrosis is an autosomal recessive disorder occurs due to abnormal gene, located on long arm of chromosome 7, that encodes cystic fibrosis transmembrane conductance regulator, CFTR. The basic abnormality lies in transport protein for Cl on apical membrane of epithelial lining of respiratory, gastrointestinal and genitourinary tracts. Figure 5.1-5 CILIARY escalator action of the respiratory mucosa. Normally in the airways of epithelial cells, Cl channel transport protein transports Cl out of the cell, resulting in retention of Na+ on the mucosal surfaces that causes water to transport through intercellular spaces. In cystic fibrosis, due to abnormal Cl channel, there is inhibition of Cl transport out of cell, leading to greater influx of Na+ in the cell, deficiency of Na, dehydration of luminal border of epithelial cell, making mucus thick and viscid, leading to deficient mucociliary escalator clearance, leading to infection. The mutations in CFTR gene that cause cystic fibrosis are grouped into 5 classes based on their cellular functions as: Class 1 mutation, inhibits synthesis of Cl channel protein. Class 2 mutation, causes defective processing of channel protein. Class 3 mutation, blocks the regulation of channel protein. Class 4 mutation, causes altered conductance through channel protein. Class 5 mutation, reduces synthesis of channel protein. Therapeutic measures advised in cystic fibrosis include: chest physiotherapy and mucolytic agents should be used to loosen thick mucus. Antibiotics to prevent infection. Bronchodilators and anti-inflammatory agents to expand and clear the airways. 2. Pulmonary alveolar macrophages play an important role in the defense system by following mechanisms. Being actively phagocytic cells, they ingest the inhaled bacteria and small particles. Help in processing inhaled antigens for immunologic attack. PAMs secrete substances that attract polymeronuclear cells to the lungs. By some secretions, they stimulate granulocyte and monocyte formation in the bone marrow. Note: the detrimental function of PAM is to digest substances inhaled in cigarette smoke or other irritants. During the digestive process, they release lysosomal products into the extracellular spaces and cause inflammatory reaction. 3. Cough reflex. The laryngeal, tracheal and bronchial mucous membranes contain vagal afferent terminals which act as irritant receptors. Stimulation of these receptors by chemical or mechanical stimuli, excessive mucus, inadvertently inhaled foodstuff, etc., produces a bout of coughing which helps in the expulsion of the foreign material. For details of cough reflex, see page 446. B. Functions subserved by pulmonary circulation. 1. Reservoir for left ventricle. When left ventricle output becomes transiently greater than systemic venous return, the blood stored in pulmonary circulation helps in maintaining the left ventricular output for few strokes. 2. Pulmonary circulation acts as a filter and filters out particles from the blood, which may include small fibrin or blood clots, detached cancer cells, fat cells, gas bubbles, agglutinated RBCs, masses of platelets and debris from stored blood. The filtered particles in the lung are removed by lytic enzyme in capillary endothelium, ingestion by macrophages and penetration into the lymphatic system. 3. Removal of fluid from alveoli. Because of low pulmonary hydrostatic pressure, the fluid entering the alveoli is absorbed by the capillaries. This protects the gas exchange function of lungs and opposes transudation of fluid from capillaries to the alveoli. 4. Role in absorption of drugs. Certain drugs that rapidly pass through the alveolar capillary barrier by diffusion are administered by inhalation, e.g. anesthetic gases, aerosol and other bronchodilators. C. Metabolic functions of lungs. 1. Surfactant produced in the lungs plays an important role in respiration. For details, see page 405. 2. Protein synthesis for maintenance of the structural framework. 3. Conversion of angiotensin I to 2 is performed by the enzyme angiotensin converting enzyme ACE, present in the pulmonary capillary endothelium. 4. Inactivation partly or completely of many vasoactive substances present in the blood is done by capillary endothelial cells as they pass through pulmonary circulation. These substances include bradykinin, serotonin, some prostaglandins, norepinephrine, acetylcholine, etc. Amount of serotonin and norepinephrine reaching the systemic circulation is decreased by lungs. Vasoactive substances that pass through the lungs without being metabolized include epinephrine, dopamine, oxytocin, vasopressin and angiotensin I. 5. Fibrinolytic mechanism present in the lung lyses clot in the pulmonary vessels. 6. Storage of hormones and certain biologically active peptides is done in the APUD cells and nerve fibers present in the alveoli. These substances include VIP, substance P, opioid peptides, cholecystokin and pancreazymin, CCKPZ, and somatostatin. These substances are later released into the systemic circulation. D. Functions subserved by respiratory muscles. Respiratory muscles are also used during laughing and singing. Chapter 5.2. Pulmonary ventilation. Introduction. Mechanics of pulmonary ventilation. Mechanism of breathing. Mechanism of tidal respiration. Mechanism of forced respiration. Pressure and volume changes during respiratory cycle. Intrapulmonary pressure changes. Intrapleural pressure changes. Lung volume changes. Pressure volume curve of the respiratory system. Lung volumes and capacities. Static lung volumes and capacities. Dynamic lung volumes and capacities. Pulmonary ELASTANCE and compliance. Pulmonary elastance. Elastance of thoracic cage. Elastance of lungs. Alveolar surface tension. Pulmonary surfactant. Pulmonary compliance. Definition and normal value. Measurement of pulmonary compliance. Static versus specific compliance. Factors affecting worker breathing. Resistance to breathing. Tissue resistance. Airway resistance. Calculation of worker breathing. In normal inspiration. In normal expiration. In restrictive lung diseases. In obstructive lung diseases. Factors affecting total worker breathing. Introduction. As we know, respiration, to be more precise the external respiration, supply of O2 from atmosphere to body tissues and removal of CO2 from the body to atmosphere, involves three major processes. Pulmonary ventilation, i.e. exchange of gases between the environment and lungs. Pulmonary diffusion, i.e. transfer of gases from the alveoli to capillary blood across the respiratory membrane and transport of gases from the blood to tissue cells and back. In this chapter, following aspects and concepts related to pulmonary ventilation are discussed. Mechanics of pulmonary ventilation. Lung volumes and capacities. Pulmonary elastance and compliance and worker breathing. Mechanics of pulmonary ventilation. Mechanism of breathing. Pulmonary ventilation is accomplished by two processes: inspiration and expiration. Inspiration refers to inflow of atmospheric air into the lungs. This obviously occurs when the intrapulmonary pressure falls below the atmospheric air pressure. Expiration refers to outflow of air from the lungs into the atmosphere. This obviously occurs when the intrapulmonary pressure rises above the atmospheric air pressure. Changes in the intrapulmonary pressure which govern the respiratory cycle of inspiration and expiration are related to changes in the intrapleural pressure. Changes in the intrapleural pressure are brought about by changes in the size of the thoracic cavity. Expansion of the thoracic cage leads to fall in intrapleural pressure, and decrease in the size of the thoracic cavity leads to rise in the intrapleural pressure. Changes in the size of the thoracic cavity are brought about by the actions of respiratory muscles. Muscles of normal tidal inspiration are diaphragm and external intercostal muscles. Accessory muscles of inspiration are scalene, sternomastoid and serratus anterior, and ali nasi. Muscles of expiration are internal intercostal muscles and abdominal muscles, abdominal recti muscles, transverse abdominis muscles and internal oblique muscles. Mechanism of tidal respiration. Inspiration. Inspiration is an active process, normally produced by contraction of the inspiratory muscles, negative pressure breathing. Use of a respirator to inflate the respiratory system produces positive pressure breathing. During tidal inspiration, quiet breathing, the diaphragm and external intercostal muscles contract and cause an increase in all the three dimensions of the thoracic cavity. Role of a diaphragm. In tidal inspiration, quiet breathing, 70–75% of the expansion of chest is caused due to the contraction of diaphragm. The diaphragm is a dome-shaped muscular tendinous partition between the thorax and abdomen. The convexity of this dome is directed towards the thorax. When the diaphragm contracts, the following changes occur. The dome becomes flattened, and the level of diaphragm is lowered, increasing the vertical diameter of the thoracic cavity, Fig. 5.2-1a. During quiet breathing, the descent of diaphragm is about 1.5 centimeters, and during forced inspiration it increases to 7 centimeters. The descent of diaphragm causes the rise in intra-abdominal pressure, which is accommodated by the reciprocal relaxation of the abdominal wall musculature. The contraction of diaphragm also lifts the lower ribs, causing thoracic expansion laterally and anteriorly, the bucket handle and pump handle effect, respectively. Figs 5.2-1b and c. The abdominal organs support the diaphragmatic dome and act as a fulcrum, while the diaphragmatic contraction raises the lower ribs. Figure 5.2-1 MECHA and ISM of increase in diameter of thoracic cavity. A. Increase in vertical diameter, descent of diaphragm. B. Increase in transverse diameter, bucket handle effect. And C. Increase in anteroposterior diameter, pump handle effect. Role of external intercostal muscles. The fibers of external intercostal muscles slope downwards and forwards. They are attached close to the vertebral ends of the upper ribs than the lower ribs, Fig. 5.2-2. From pivot-like joint with the vertebrae, the ribs slope obliquely downwards and forwards. So, when the external intercostal muscles contract because of the lever effect, the ribs are elevated, causing the lateral and anteroposterior enlargement of the thoracic cavity due to the so-called bucket and pump handle effects, respectively, Figs. 5.2-1b and c. Figure 5.2-2 CONTRACTION of external intercostal muscle favors elevation of ribs due to mechanical leverage effect of the attachments of its fibers close to the pivot on the upper ribs as compared to lower ribs. Role of laryngeal muscles. The abductor muscles of the larynx contract during inspiration, pulling the vocal cords apart. Expiration. Expiration in quiet breathing is largely a passive phenomenon and is brought about by the following. Elastic recoil of the lungs. Decrease in the size of the thoracic cavity due to the relaxation of diaphragm and external intercostal muscles. An increase in the tone of muscle of the anterior abdominal wall, which forces the relaxing diaphragm upwards, and the serratus posterior inferior muscles that play a minor role in pulling down the ribs. Applied aspects. Hiccup is a spasmodic contraction of diaphragm and other inspiratory muscles, resulting in inspiration in which there is a sudden closure of glottis, producing sound and a characteristic sensation. Its physiological significance is not yet clear. Usually, hiccup is of short duration, but when it becomes debilitating, then use of dopamine antagonist and centrally acting analgesics may help. In bilateral phrenic nerve palsy, adequate ventilation at rest can be maintained by the external intercostal muscles alone, but respiration is somewhat labored to maintain life. Spinal cord transaction above the level of the third cervical segment is fatal without artificial respiration, whereas in transaction below the fifth cervical segment, respiration remains normal as the phrenic nerve C3, C4, C5 that innervates the diaphragm remains intact. Mechanism of forced respiration. Forced inspiration. Forced inspiration is characterized by 1. Forceful contraction of diaphragm leading to the descent of diaphragm by 7 to 10 cm as compared to 1-1.5 cm during quiet inspiration. 2. Forceful contraction of external intercostal muscles causing more elevation of ribs leading to more increase in transverse and anteroposterior diameter of the thoracic cavity. 3. Contraction of accessory muscles of inspiration which causes the following effects. Sternomastoid muscles contract and lift the sternum upwards. Anterioceratee muscles contract and lift many of the ribs upwards. Scalene muscles contract and lift the first two ribs. Forced expiration. Forced expiration is required when respiration is increased during exercise or in the presence of severe respiratory disease. It is an active process that gives rise to the following. 1. Contraction of abdominal muscles. Compression of the abdominal contents which increases the intra-abdominal pressure and forces the diaphragm upwards, thereby reducing the vertical diameter of the thoracic cavity. Downward pull on the lower ribs, thus decreasing the anteroposterior diameter of the thoracic cavity. Fixation of the lower ribs so that internal intercostal muscles act more effectively. 2. Contraction of the internal intercostal. It causes the effect which is just opposite to that of external intercostal muscles. This is because of the leverage mechanism of the direction of the muscle fibers which slope downwards and backwards, creating a longer force arm for the upper ribs, Fig. 5.2-3. Hence, their contraction tends to pull all the ribs downwards, thereby reducing the anteroposterior diameter, because of the falling of the pump handle effect. As well as the transverse diameter, because of the action of ribs like the falling of the bucket handle effect. Of the thoracic cavity. Figure 5.2-3 CONTRACTION of internal intercostal muscle pulls the ribs down due to mechanical leverage effect of its fibers close to the pivot on the lower ribs as compared to upper ribs. Note. Besides their role in deep breathing, the expiratory muscles are also involved in other forced expiratory efforts, e.g. in coughing, vomiting, defecation and Valsalva maneuver, etc. Pressure and volume changes during the respiratory cycle. Pressure changes. Intrapulmonary pressure changes during the respiratory cycle, Fig. 5.2-4. The movement of air in and out of the lungs depends primarily on the pressure gradient between the alveoli and the atmosphere, i.e. transairway pressure. The intrapulmonary or alveolar pressure is the air pressure inside the lung alveoli. At end expiration and end inspiration, i.e. when the glottis is open and there is no movement of air, the pressures in all parts of the respiratory tree are equal to the atmospheric pressure, and the intrapulmonary pressure is considered to be 0 mm of Hg. During inspiration in quiet breathing, the pressure in the alveoli decreases to about -1 mm of mercury, which is sufficient to suck in about 500 milliliters of air into the lungs within 2 seconds of inspiration. At the end inspiration, the intrapulmonary pressure again becomes 0. During forced inspiration against a closed glottis, Muller's maneuver, the intrapulmonary pressure may be as low as -80 mm of mercury, i.e. below the atmospheric pressure. During expiration in quiet breathing, the elastic recoil of the lungs causes the intrapulmonary pressure to swing slightly to the positive side +1 mmHg, which forces the 500 milliliters of inspired air out of the lungs during 2 to 3 sec of expiration. At the end expiration, once again the alveolar pressure regains the atmospheric pressure, 0 mm of Hg. Forceful expiration against closed glottis, Valsalva's maneuver, may produce the intrapulmonary pressure of as much as 100 mm of mercury. Figure 5.2-4 PRESSURE and volume changes during the respiratory cycle. Intrapleural pleural pressure changes during the respiratory cycle, Fig. 5.2-4. Pleural pressure is the pressure of fluid in the space between the visceral pleura and parietal pleura. Normal pleural pressure, when the respiratory muscles are completely relaxed and the airways are open, is about -2.5 mm of mercury. The negative pleural pressure, -2.5 mm of mercury, is the amount of suction required to hold the lungs at their equilibrium volume or the functional residual capacity, FRC. FRC is the lung volume at the end of normal, eupnoic, relaxed expiration and is about 2-2.5 L of gas. The negative pleural pressure, -2.5 mm of mercury, is the result of balance of two opposite forces, the recoil tendency of the lungs and the recoil tendency of the thoracic cage. Recoil tendency of the lungs, continuous tendency to collapse, is caused by the presence of many elastic fibers in the alveolar walls which are under constant stretch in the inflated lungs and surface tension of the fluid lining the alveoli, due to which the alveoli tend to become progressively smaller and collapse. Recoil tendency of the thoracic cage, i.e. a constant tendency to expand, to pop outwards, is because of the fact that the chest wall is an elastic structure which is normally partially pulled inwards. The elastic property of the thoracic cage is because of the elastic nature of ribs, muscles and tendons. During inspiration, due to the expansion of the chest wall, the pleural pressure becomes more negative, -6 mm of Hg, and pulls the surface of lungs with greater force, creating negative intrapulmonary pressure. During expiration, at the end of inspiration, the inspiratory muscles relax and the recoiling force of lungs begins to pull the chest wall back to expiratory position. At end expiratory position, where the recoil force of the lungs and recoil force of thoracic cage balance, the pleural pressure returns back to minus 2.5 millimeters of mercury. Factors affecting pleural pressure. 1. Deep inspirations. The pleural pressure may become as low as minus 30 millimeters of mercury during deep inspiration. 2. Valsalva maneuver, or when expiratory muscles work against closed glottis, there occurs a marked decrease in the thoracic volume causing deflation of lungs. Under such circumstances, the intrapleural pressure can become positive by 60 to 70 mmHg, greater than atmospheric pressure, e.g. during defecation and coughing. 3. Gravity. The pleural pressure in standing position is more negative minus 7 millimeters of mercury. At the apices of the lungs as compared to the bases, minus 2 millimeters of mercury. Because of this, lungs are less expanded at the base and even the airway at the base may become closed at the end of expiration. This is why during the first part of inspiration, more of the inspired gas goes to the apices than bases of lungs. 4. Injury to the chest wall causing exposure of the pleural cavity to the exterior causes air to enter the pleural cavity, pneumothorax. And the pleural pressure rises from the subatmospheric level to the atmospheric level. Since there is no opposing force to the elastic recoil of the lung, so in pneumothorax the lung is collapsed. 5. Emphysema is a disease of the lungs in which lung elasticity is decreased or lost. Due to the decrease in the recoiling force of lungs, the intrapleural pressure becomes less negative, i.e. increases. Because of this reason, in this disease, the lung alveoli expands and chest also expands and becomes barrel-shaped. Effects of pleural pressure on the cardiovascular system. 1. During inspiration, when the pleural pressure becomes more negative, the mediastinal pressure also becomes more negative, leading to the expansion of the walled structures in the thorax, especially large veins, superior and inferior vena cavae, and thereby decreasing pressure on them. This causes blood to be sucked into these veins from extrathoracic regions. Thus, there is increased venous return to the heart during inspiration due to suction action of the respiratory pump. The descent of diaphragm during inspiration causes a slight rise in intra-abdominal pressure, thereby increasing the pressure gradient between abdomen and thorax further. The increase in the venous return during inspiration increases the cardiac output. This respiratory pump action is especially marked during exercise. 2. During Valsalva maneuver, or when expiratory muscles are working violently against closed glottis, e.g. while severe bouts of cough, the pleural pressure becomes positive, leading to a decrease in the venous return. So the cardiac output is markedly decreased and there may occur cerebral ischemia, visual blackouts and unconsciousness, especially in old persons. Measurement of pleural pressure. 1. Manometric measurement can be made by inserting a needle into the intrapleural space whose other end is attached to a water manometer with the help of a rubber tubing. 2. Intraoesophageal pressure can be recorded with the help of an air-containing rubber balloon sealed over a catheter placed in the lower part of thoracic part of esophagus. Intraoesophageal pressure in the thoracic part is equivalent to the intrapleural pressure because this part of esophagus becomes a closed cavity due to the closure of its lower end by the cardiac sphincter and upper end by the closure of glottis. Lung volume changes during the respiratory cycle. During tidal inspiration, the volume of air in the lungs increases by 500 milliliters, tidal volume. During tidal expiration, the elastic forces compress the gas in the lungs which starts flowing out, and at the end of expiration the volume of air in the lungs decreases by 500 milliliters, Fig. 5.2-4. Pressure volume curve of respiratory system. The transrespiratory pressure, TRP, refers to the transmural pressure across the entire respiratory system. It equals alveolar pressure, PA, minus pressure at the body surface, PBs, i.e. TRP equals PA, PBs. The pressure at the body surface is usually atmospheric pressure. Pressure volume curve of the respiratory system, Fig. 5.2-5 shows that it is a sigmoid-shaped curve which is residual volume, RV, and total lung capacity, TLC, are limited by the decreased compliance of the system as indicated by the reduced slope of the curve at both extremes. Figure 5.2-6a. Residual. The help of an air-containing rubber balloon sealed over a catheter placed in the lower part of thoracic. Intraoesophageal lung volume changes during the respiratory cycle. During tidal inspiration, the volume of air in the lungs increases by 500 milliliters, tidal volume. During tidal expiration, the elastic forces compress the gas in the lungs which starts flowing out, and at the end of expiration the volume of air in the lungs decreases by 500 milliliters, Fig. 5.2-4. Pressure volume curve of respiratory system. The transrespiratory pressure, TRP, refers to the transmural pressure across the entire respiratory system. It equals alveolar pressure, PA, minus pressure at the body surface, PBs, i.e. TRP equals PA, PBs. The pressure at the body surface is usually atmospheric pressure. Pressure volume curve of the respiratory system, Fig. 5.2-5 shows that it is a sigmoid-shaped curve which is steepest in the middle and almost flat at both high and low lung volumes. FRC is determined by the volume at which the transrespiratory pressure, TRP, is 0. Residual volume, RV, and total lung capacity, TLC, are limited by the decreased compliance of the system as indicated by the reduced slope of the curve at both extreme volumes. Figure 5.2-5 PRESSURE volume curve of the respiratory system. RV equals residual volume, FRC equals functional residual capacity, and TLC equals total lung capacity. Lung volumes and capacities. Static lung volumes and capacities. Lung volumes. The maximum volume to which a lung can be expanded has been divided into 4 non-overlapping volumes, Fig. 5.2-6. Figure 5.2-6a diagram showing various lung volumes and capacities. RV equals residual volume. TV equals tidal volume. ERV equals inspiratory reserve volume. ERV equals expiratory reserve volume. FRC equals functional residual capacity. TLC equals total lung capacity. IC equals inspiratory capacity. VC equals vital capacity and EC equals expiratory capacity. 1. Tidal volume TV. It is the volume of air inspired or expired with each breath during normal quiet breathing. It is approximately 500 milliliters in a normal adult male. 2. Inspiratory reserve volume ERV. It is the extra volume of air that can be inhaled by a maximum inspiratory effort over and beyond the normal tidal L volume. It is about 3,000 milliliters in a normal adult male. 3. Expiratory reserve volume ERV. It is the extra volume of air that can be exhaled by maximum forceful expiration over and beyond the normal tidal volume, i.e. after the end of normal passive expiration. It is approximately 1,100 milliliters in a normal adult male. 4. Residual volume RV. It is the volume of the air that still remains in the lungs after the most forceful expiration. It is about 1,200 milliliters in a normal adult male. Lung capacities. Lung capacity is a combination of two or more pulmonary volumes and include Fig. 5.2-6. 1. Inspiratory capacity, IC. This is the maximum volume of the air that can be inspired after normal tidal expiration. Therefore, it equals the tidal volume plus inspiratory reserve volume TV plus ERV, and is approximately 3,500 milliliters in a normal adult male. 2. Expiratory capacity. It is the maximum volume of air that can be expired after normal tidal inspiration. It equals tidal volume plus expiratory reserve volume TV plus ERV, and is approximately about 1,600 milliliters in a normal adult male. 3. Functional residual capacity, FRC. It is the volume of the air remaining in the lungs after normal tidal expiration. Therefore, it equals the expiratory reserve volume plus the residual volume ERV plus RV, and is about 2,300 milliliters in a normal adult male. Significance of FRC. The FRC, RV plus ERV, of about 2,300 milliliters represents the air that remains in the lungs most of the times. Even after the most forceful expiration, about 1,200 milliliters, residual volume. Air is always present in the lungs. This has several advantages. Continuous exchange of gases is possible due to presence of some air always in the lungs, and thereby concentration of O2 and CO2 in blood are maintained constant. Without FRC, PO2 would have risen to 150 millimeters of mercury during inspiration, and reduced nearly to zero during expiration, which is maintained at about 100 millimeters of Hg due to the FRC. Breath holding is made possible due to the FRC. Dilution of toxic inhaled gases occurs due to the reserve of 2,300 milliliters of air in the lungs, FRC. Most of the times. IV. Load on respiratory mechanism and left ventricle would have been much more if there was no FRC, since without FRC, lungs would have collapsed at the end of each expiration, and re-expansion would have required tremendous breathing effort, and the collapsed lungs would have increased pulmonary vascular resistance and imposed a heavy load on left ventricle. Factors affecting FRC. Hyperinflation of the lungs seen in following conditions may be associated with increased FRC. Old age due to loss of elasticity of lungs, emphysema, and bronchial asthma. Measurement of FRC. Functional residual capacity can be measured by the nitrogen washout method or the helium dilution method. Nitrogen washout method for measuring FRC. This method is based on the assumption that the alveolar air has 80% nitrogen. In this method, the subject is made to wash out nitrogen from the lungs completely by inhaling pure O2 for 5 minutes and expiring into a large gas bag called the Douglas bag, washed with pure O2 and hence made nitrogen-free. The volume of gas collected in the Douglas bag and its nitrogen content are measured, and the value of FRC is calculated as follows. Suppose that the expired gas collected at the end of 5 minutes is 40 L and its nitrogen concentration is 5%. Then the volume of nitrogen, Vn, in the expired gas will be 45,100 equals 2 L or 2,000 milliliters. Since the nitrogen content of the expired gas is solely from the subject's lungs where it forms 80% of the gas present in the lungs, FRC. Therefore, FRC equals 2,000 10,080 milliliters equals 2,500 milliliters or 2.5 L. Helium dilution method for FRC estimation. This method is based on the basic principle that the amount A of a substance present is equal to its volume, V, multiplied by its concentration, C, i.e. R equals Vc. In this method, a closed-circuit system is prepared with a mixture of helium, oxygen and air. The amount of helium is added in the mixture such as to achieve a helium concentration of 10%. The subject is then made to breathe in the closed system till the concentration of helium in the lungs and the bag becomes equal. The helium concentration is measured at the end of a normal expiration, because the FRC is the volume of air remaining in the lungs at the end of normal expiration. Since no helium was present in the lungs to start with, the same amount of helium which was added in the mixture in the closed-circuit system gets distributed between the bag and the lungs, Figs 5.2-7a and b. The FRC can be calculated as follows. Suppose that the volume of helium added in the mixture to make its concentration to 10% is 560 milliliters. Volume of the bag is 5,000 milliliters and concentration of helium, He. in the bag and lungs after breathing in the closed-circuit system is 8%. Then, the volume of He equals volume of lungs plus bag concentration of helium, 8,100, i.e. 560 equals volume of lungs plus 5000, 8,100, or volume of lungs plus 5000 equals 500, 1008, or volume of lungs equals 7,000, 5,000, hence, FRC equals 2,000 milliliters. Figure 5.2-7 HELIUM dilution method for estimation of functional residual capacity, FRC. A. In the beginning no helium present in the lungs, and B. The helium present in closed circuit distributed equally between bag and the lungs. 4. Vital capacity, VC. This is the maximum amount of air a person can expel from the lungs after the deepest possible inspiration. Therefore, it equals the tidal volume plus the inspiratory reserve volume plus the expiratory reserve volume TV plus ERV plus ERV. And is about 4,600 milliliters in a normal adult male. Significance of vital capacity. Estimation of VC allows the assessment of maximum inspiratory and expiratory efforts and thus gives useful information about the strength of respiratory muscles. VC also provides useful information about other aspects of pulmonary functions through FEV, see page 407. Factors affecting vital capacity. I. Size of the thoracic cavity. VC is more in males 2.6 L per square meter body surface area. Because of large chest size and more muscle power than females. II. Age. In old age, VC decreases due to the decrease in the elasticity of the lungs. III. Strength of respiratory muscles. In swimmers and divers, VC is more because of the increased strength of the respiratory muscles. IV. Gravity. In standing position, VC is more than in sitting and lying position because of increased size of the thoracic cavity in standing, diaphragm moves down, and reduced pulmonary blood flow due to decreased venous return. V. In pregnancy, VC is reduced due to pushing up of the diaphragm and the reduced capacity of the thoracic cavity. VI. In ascites, accumulation of fluid in the abdominal cavity, VC is reduced due to the same reason as in pregnancy. 7. Pulmonary diseases such as pulmonary fibrosis, emphysema, respiratory obstruction, pulmonary edema, pleural effusion and pneumothorax are associated with decreased VC. 5. Total lung capacity, TLC. It is the volume of air present in the lungs after the maximal inspiration. It equals the vital capacity plus the residual volume, VC plus RV. And is about 5,800 milliliters in a normal adult male. Measurement of static lung volumes and capacities. All volumes and capacities except residual volume, functional residual capacity and TLC are recorded by a spirometer. Functional residual capacity is determined by the nitrogen washout method or the helium dilution method, and then residual volume and TLC are calculated. Recording of lung volumes and capacities are the important lung function tests. For details see page 473. Dynamic lung volumes and capacities. Timed vital capacity, TVC, or forced vital capacities. Forced vital capacity is the volume of the air that can be expired rapidly with a maximum force following a maximum inspiration. The volume of air expired can be timed by recording the vital capacity on a spirograph moving at the known speed. Components are TVC or FVC, Fig. 5.2-8. I. Forced expiratory volume in 1 second, FEV1. It represents the volume expired in the first second of an FVC. Estimation of FEV1 is the most commonly used screening test for airway diseases. The FEV1 is actually a flow rate. Its unit is L, sec. FEV 1% is the percent of FVC expired in 1 second, i.e. FEV 1% equals FEV1, FVC 100. Normally, FEV 1% is about 80% of the FVC, Fig. 5.2-9a. Clinical application. Useful in distinguishing between restrictive and obstructive lung diseases. Patients with restrictive lung disease, RLD, e.g. kyphoscoliosis and ankylosing spondylitis, have a reduced FVC, but they are able to achieve relatively high flow rates. Therefore, their FEV 1% exceeds 80%, Fig. 5.2-9b. Patients with obstructive lung disease, OLD, e.g. bronchial asthma, have low flow rates as a result of high airway resistance. Therefore, their FEV 1% is abnormally low, Fig. 5.2-9c. Figure 5.2-9 FORCED expiratory volume in first second, FEV1, component of timed vital capacity. A. In normal subject. B. In a patient with restrictive lung disease, RLD. And C. In a patient with obstructive lung disease, OLD. II. Forced expiratory volume in 2 seconds, FEV2. It represents the volume of air expired in the first 2 seconds of FVC. FEV 2% is about 90% of FVC under the normal condition. III. Forced expiratory volume in 3 seconds, FEV3. It represents the volume of air expired in the first 3 seconds. Normally FEV 3% is 98% minus 100% of FVC. Figure 5.2-8 COMPONENTS a timed vital capacity. Forced expiratory flow during 25% minus 75% of expiration, FEF 25% minus 75%. It is the mean expiratory flow rate during middle 50% of FVC, Fig. 5.2-10a. Normal FEF 25% minus 75% is 300 L per minute. Mid-expiratory time, MET, refers to the time taken for FEF 25 and minus 75%. Its normal value is 0.5 seconds, which is increased in obstructive lung disorders. Figure 5.2-10 FORCED expiratory flow. A. During 25-75% of expiration, FEF 25-75%. And B. During 200 ml of expiration, FEF 200 ml. Forced expiratory flow during 200 ml of expiration, FEF 200 FEF 200 refers to the mean expiratory flow rate between the 200 and 1,200 milliliters segment of FVC, Fig. 5.2-10b. Normal values of FEF 200 is 350 L per minute. Minute ventilation, MV, or pulmonary ventilation, PV. It is the volume of air inspired or expired per minute. It equals the tidal volume multiplied by the respiratory rate, TVRR. The TV at rest averages 500 milliliters, 0.5 L, and the normal respiratory rate is 12 to 15 breaths per minute. Therefore, normal minute volume is 6-7.5 L per minute. Maximum breathing capacity, MBC, or maximum voluntary ventilation or maximum ventilation volume, MVV. It is the maximum volume of air that can be ventilated on command during a given interval. This index of ventilatory function depends upon the complete cooperation of the subject, who is asked to breathe as rapidly and deeply as she can for a 15-sec interval. The volume of the air moved is either recorded by a spirometer fitted with a writing point or is collected in a Douglas bag. The result is expressed in L per minute. A normal adult male can attain an MVV of 80 to 170 L per minute, average 100 L per minute. MVV is profoundly reduced in patients with emphysema, airway obstruction, and very poor respiratory muscle strength. Important note. Hyperventilation causes CO2 washout, which leads to respiratory depression. This may result in fainting. Therefore, voluntary hyperventilation should be done for the brief periods, 15 seconds only. Pulmonary reserve or breathing reserve. Pulmonary reserve, PR, refers to the maximum amount of the air above the pulmonary ventilation that can be inspired or expired in 1 minute. It equals the maximum ventilation volume minus pulmonary ventilation, minute ventilation, i.e. PR equals MVV PV per minute. Pulmonary reserve is usually expressed as the percentage of MVV and is known as the percentage pulmonary reserve or the dyspnoic index DI, i.e. DIMVV, PV MVV 100. Normal values of DI or percent PR range from 60% to 90% with an average of 75%. Dyspnea is usually present when the value of DI becomes less than 60%. Pulmonary elastance and compliance. Pulmonary elastance. Elastance refers to the recoil, retractive tendency of a structure. Both the thoracic cage and lungs have elastance. Elastance of thoracic cage. Elastance or the recoil tendency of the thoracic cage refers to the constant tendency of the thoracic cage to expand, to pop outward. The elastance of the thoracic cage is because of the fact that the chest wall is an elastic structure which is normally kept partially pulled inward. The elastic property of the thoracic cage is because of the elastic nature of ribs, muscles, and tendons. Elastance of lungs. Elastance or recoil tendency of the lungs refer to the constant tendency of the lungs to collapse. The recoil forces in the lungs are generated by 1. Tissue forces. These are due to the presence of many elastic tissues such as smooth muscle, elastic and collagen in the lung parenchyma, which are kept under constant stretch in the inflated lungs. However, the role of these connective tissue fibers in generating elastic retractile forces in the lungs is not fully elucidated. 2. Surface forces. These are generated at the alveolar surface line by fluid alveolar surface tension, due to which the alveoli tend to become progressively smaller and tend to collapse. The alveolar surface tension needs further discussion since it is responsible for about 2/3 of total elastic forces in the lungs. Alveolar surface tension. Alveolar surface tension is generated because of the unbalanced attraction of the liquid molecules at the surface of alveolar membrane. A phase change occurs between the alveolar gas and the surface of the alveolar membrane. Alveolar surface tension has a tendency to reduce the size of each alveolus, thus resulting into recoil tendency of the lung, i.e. surface tension increases the tendency of the lungs to deflate. An increased transmural pressure is necessary to counteract the effects of surface tension. According to the law of Laplace, in a spherical structure like alveoli, the transmural pressure generated equals 2 times the surface tension divided by radius, i.e. P equals 2T/R. In other words, the pressure in the alveoli is directly proportionate to the surface tension and inversely proportionate to the radii. Therefore, small alveoli tend to become still smaller, whereas large alveoli tend to become still larger, Fig. 5.2-11. Thus, surface tension tends to produce collapse of the alveoli. Figure 5.2-11 PRESSURE in the alveoli P is directly proportionate to the surface tension, T, and inversely proportionate to the radii, R. Therefore, small alveoli tend to become still smaller and large alveoli tend to become still larger. Alveolar surface tension playing a major role in generating elastance forces in the lungs can be demonstrated by an experiment, see page 408. Pulmonary surfactant. The alveolar surface tension opposes the expansion of the lungs during inspiration. The surface tension of pure water and air interface is so high that every inspiration would require an exhausting muscular effort. However, the presence of pulmonary surfactant in the fluid lining the alveoli reduces the surface tension markedly. Source. Pulmonary surfactant is secreted by type 2 alveolar epithelial cells, granular pneumocytes. In the cells, it is stored in lamellar bodies. It comes to the surface of alveoli by the process of exocytosis and mixes with the water molecules present there. Composition. Pulmonary surfactant is a complex mixture of several phospholipids, proteins and ions. 4 unique proteins have been identified in surfactant: SPA, SPB, SPC and SPD. SPA and SPD are hydrophilic proteins, and SPB and SPC are strongly hydrophobic proteins. Dipalmitoylphosphatidylcholine, DPP. Dipalmitoylphosphatidylcholine, DPPC, along with several other phospholipids, is responsible for reducing surface tension. Mechanism of action. One portion of each phospholipid molecule is hydrophilic and dissolves in the water lining the alveoli. Lipid hydrophobic portion of the molecule is oriented towards the air. This causes spreading of surfactant molecules over the surface of fluid lining the alveoli. Apoproteins and calcium ions are responsible for uniform and quick spreading of surfactant molecules over the surface. Such a hydrophobic surface exposed to air has 1/12 to 1/2 of the surface tension of a pure water surface, depending upon the concentrations and orientation of surfactant molecules on the surface. Surface tension with normal alveolar fluid lining without surfactant is about 50 dynes per square centimeter, and with surfactant it varies between 5 and 30 dynes per square centimeter, depending upon the concentration of surfactant. Functions of pulmonary surfactant. 1. Reduces the tendency of alveoli to collapse. The surface tension in a thin-walled sphere like alveolus tends to make the sphere smaller to collapse. Surfactant, by reducing surface tension, decreases the tendency to collapse. 2. Reduces worker breathing. According to Laplace's law, due to reduction in the surface tension, the mean alveolar radius is increased. This reduces the transmural pressure required for expanding the alveoli. As alveoli are easily expanded, so worker breathing is reduced. The low surface tension also facilitates the reopening of collapsed airway and alveoli. 3. Prevents pulmonary edema. Surface tension is retracting force which not only pulls alveolar wall to the center of alveolus but also pulls fluid from capillaries into the interstitial space surrounding the alveoli and into the alveoli, leading to pulmonary edema. Surfactant prevents this phenomenon by lowering the surface tension. 4. Alveolar stabilization. Surfactant causes stability of alveoli, i.e., it maintains almost uniform size of alveoli. Due to pulmonary surfactant, pulling pressure in the alveoli is reduced from 18 centimeters of H2O to 4 centimeters of H2O. The mechanism of alveolar instability and how the pulmonary surfactant causes alveolar stabilization is explained. Alveolar instability due to surface tension effect is produced as follows. In the two alveoli, with unequal size, connected to each other, the amount of pressure generated in each according to Laplace's law will be pressure equals 2 surface tension radius. Thus, when the surface tension is constant, the pressure developed in the smaller alveolus will be more than the larger alveolus. This will cause pushing of air from smaller alveolus with higher pressure to large alveolus with lower pressure. As a result, the smaller alveolar sac will become more smaller and larger alveolar sac will become more larger. Fig. 5.2-11. The above cycle of pushing air from smaller to larger sac will continue till the smaller sac totally collapses, leading to large distension of the other sac, thereby producing instability of the alveoli. Pulmonary surfactant causes alveolar stabilization by following mechanisms. In the presence of surfactant, the surface tension developed in the alveoli is inversely proportionate to the concentration of surfactant per unit area. In the smaller alveolus, the surfactant molecules form a thick layer, while in a larger alveolus the surfactant molecules are scattered on the larger surface, as number of molecules is limited. Fig. 5.2-12. Thus, in a smaller alveolus the tendency to develop more pressure due to smaller radius will be neutralized by the tendency to develop less pressure due to more concentration of surfactant per unit area. And the reverse will occur in larger alveolus. In this way, there will not be much pressure gradient between the two alveoli, helping to maintain the size of alveolar sac constant. Thus, due to the presence of surfactant, stability of alveoli is maintained. Figure 5.2-12 distribution of surfactant in A. Large and B. Small alveoli. Other factors which help in alveolar stabilization along with surfactant are interdependence and fibrous tissue. Interdependence is a mechanical method of alveolar stabilization. The alveolar septa form a continuous network that is under tension because of lung inflation. Alveoli are tethered together by their adjoining walls and cannot change volume independently of the neighboring lung tissue. Fibrous tissue. The lung is constructed of about 50,000 functional units, each of which contains one or a few alveolar ducts and their associated alveoli. All of these are surrounded by fibrous septa that act as additional splints and stabilize the alveoli. Factors affecting pulmonary surfactant. Factors which decrease the pulmonary surfactant. Long-term inhalation of 100% O2. Occlusion of main bronchus. Occlusion of one pulmonary artery. Cigarette smoking, and cutting both the vagi. Factors which increase surfactant production. Thyroid hormones increase the secretion of pulmonary surfactant by increasing the size and number of inclusion bodies in type 2 alveolar lining epithelial cells. Glucocorticoids accelerate the maturation of pulmonary surfactant. Applied aspects. Clinical significance of pulmonary surfactant. 1. Respiratory distress syndrome of newborn or the hyaline membrane disease occurs in the newborn babies, especially premature, due to inadequate formation of surfactant, resulting in an elevated alveolar surface tension. Retention of fluid in the lung is an additional factor in respiratory distress syndrome, RDS. During fetal life, pulmonary epithelium secretes Cl in the fluid, but at birth epithelial cells start absorbing Na+ through epithelial Na+ channels, NACs. And fluid gets absorbed along with Na+. Immaturity of NACs is responsible for pulmonary edema in RDs. Under this condition, it is extremely difficult to expand the lungs. Dysfunction. Overproduction of surfactant proteins is the cause of pulmonary alveolar proteinosis and can lead to respiratory distress. Under this condition, it is extremely difficult to expand the lungs. Sign and symptoms. Respiratory work is greatly increased and there is inadequate exchange of gases due to alveolar instability, pulmonary edema and collapse of alveoli, atelectasis. In many areas, this results in severe respiratory insufficiency and the infant may die. Diagnosis. Plasma levels of thyroid hormones and cortisol are low in infants with RDs. Treatment. Therapy of RDs includes administration of exogenous surfactant and application of positive end expiratory pressure, PEEP. 2. Adult respiratory distress syndrome occurs due to abnormal surfactant function caused by a variety of severe pulmonary injuries. Clinical trials are now underway using exogenous surfactant in an attempt to improve the outcome in adults. 3. Patchy atelectasis occurs due to surfactant abnormality in patients who have undergone cardiac surgery during which a pump oxygenator is used and the pulmonary circulation is interrupted. Pulmonary compliance. Definition and normal value. Compliance, C, refers to change in lung volume, delta V, per unit change in transpulmonary pressure, delta P, i.e. C delta V delta P. Transpulmonary pressure is the difference in the pressure between alveolar pressure and pleural pressure. Compliance expresses the distensibility, expansibility of the lung and chest wall. Normal value of compliance for the lungs and chest wall combined is 0.13 L per centimeter of H2O and for the lung alone it is 0.22 L per centimeter of H2O. Measurement of total compliance. Total respiratory compliance, combined compliance of chest wall and lungs, can be measured by the pressure-volume curve of the respiratory system. The pressure-volume curve of the respiratory system can be obtained in living subjects by using a spirometer as below. Procedure. The subject is connected to the spirometer and asked to breathe air through mouth with nostrils closed. The manometer attached with the spirometer measures airway pressure, transpulmonary pressure. The subject inhales known volume of air from end expiratory position, and the valve of the spirometer is then shut off to close the airway. The subject holds the breath and then releases the respiratory muscles and change in the airway pressure is measured. The procedure is repeated with actively inhaling or exhaling different air volumes up to the maximum. The change in the airway pressure is plotted against each air volume and a curve obtained is called the pressure-volume curve of the respiratory system, Fig. 5.2-13. Figure 5.2-13 PRESSURE volume curve of the respiratory system. Observations and inferences. 1. The pressure-volume curve of the respiratory system is a sigmoid-shaped curve which is steepest at the middle and almost flat at both ends, i.e. high and low lung volumes. 2. The volume at which air pressure is 0 mm of mercury, atmospheric pressure, is called relaxation volume, which is equal to FRC. At relaxation volume, the recoil of chest wall and recoil of lung balance each other. 3. Above relaxation volume, on increasing lung volumes there is increase in the airway pressure and at maximum inspiration pressure rises up to 30 mm of mercury. On the other hand, decrease in the lung volumes below relaxation volume, airway pressure decreases and at maximum expiration point it decreases up to minus 30 mm of mercury. 4. The RV and TLC are limited by decreased compliance of the system as indicated by the reduced slop at both extreme volumes. Factors affecting compliance of lungs and chest wall. Downward and right shift of the pressure volume curve indicates decreased total respiratory compliance. The causes of decreased compliance are pulmonary congestion, interstitial pulmonary fibrosis, pulmonary edema. Upward and left shift of the pressure volume curve indicates increases total respiratory compliance. The causes of increased compliance are emphysema, old age, measurement of pulmonary compliance. The compliance of lung alone can be measured by measuring the intrapleural pressure at different lung volumes. The intrapleural pressure, being similar to intraesophageal pressure, is measured with the help of an intraesophageal balloon connected to a manometer. The subject is made to inspire air from a spirometer in steps of 100 milliliters and each time the intrapleural pressure is recorded. The relationship of lung volume to intrapleural pressure is plotted on a graph which gives the inspiratory compliance curve Fig. 5.2-14. Similarly, expiration is also done in steps and expiratory compliance curve is obtained Fig. 5.2-14. The inspiratory and expiratory compliance curves do not coincide but form a loop called hysteresis loop. So, Figure 5.2-14 shows that the lung volume at any given pressure is greater during expiration than during inspiration. This is due to difference in the distensibility, stretchability of the lungs between inspiratory and expiratory phases. The volume midway between the hysteresis loop dashed linear line Fig. 5.2-14 gives the average compliance of the lungs. Had the lungs been a perfectly elastic structure like a spring, the pressure-volume relation line would have been linear, Hooke's law. The curved lines obtained during inspiration and expiration are because of two resistances. Viscous resistance due to non-elastic tissues in the lungs, and airway resistance. Therefore, to calculate the compliance of the lung, the point on the graph at the end of inspiration, i.e. when there is no airflow, should be considered. At this point there is no airway resistance and no viscous resistance. The compliance calculated from pressure and volume changes at this point indicates the compliance of lung alone due to elastic tissue only. Figure 5.2-14 CHANGE in volume per unit change in intrapleural pressure during quiet respiration. The dotted line represents the pulmonary compliance. Static versus specific lung compliance. Static compliance. The compliance measured as described above is the static compliance. The static compliance of any system is dependent on its size. Thus, the lung compliance depends upon the amount of functional lung tissue. Thus, static compliance is not a good measure of absolute distensibility, as is clear from the following example. For example, if a patient's lung compliance is 0.22 L per centimeter H2O, then both lungs together are able to expand 0.22 L for each cm H2O change in pleural pressure. Assuming equal compliance in both lungs, each lung will take up 0.11 L of gas. If the patient undergoes a pneumonectomy, the compliance measured will be only 0.11 L per centimeter H2O, in spite of the fact that distensibility of the remaining lung is normal. Therefore, clinically term specific compliance is used. Specific compliance is the compliance of the lung at relaxation volume, the point at the end of a tidal expiration, i.e. the functional residual capacity. The specific compliance is expressed per liter of functional residual capacity, FRC. It is a measure of the absolute distensibility of a structure. For instance, in the above cited example, if the FRC is 2.2 L, then specific compliance with both intact lungs will be equals 0.222.2 equals 0.1 L per centimeter H2O. Specific compliance after pneumonectomy of one lung will be 1111 equals 0.1 L per centimeter H2O. Factors affecting lung compliance. Lung compliance is inversely proportionate to the lung elastance, elastic recoil force. Therefore, lung compliance is determined on the basis of following elastic forces. Elastic forces of the lung tissues due to elastic and collagen fibers contribute smaller amount of elasticity. Elastic forces caused by surface tension within the alveoli account for about 2/3 of total elastic forces in the lungs. Alveolar surface tension plays a major role in generating elastance forces in the lungs and thus is very important factor affecting lung compliance. It can be demonstrated experimentally by recording the compliance of an isolated lung of an animal by first distending it with air and then with saline. Filling the lungs with saline theoretically eliminates the force of surface tension so that only the elastic forces of the lung tissue produce recoil. Figure 5.2-15 shows the results of such an experiment. Compared with air-filled lungs, Fig. 5.2-15a, the saline-filled lungs, Fig. 5.2-15b. Markedly reduce recoil forces, leading to the conclusion that the elastic forces caused by alveolar surface tension play a major role in generating elastance forces in the lungs. Figure 5.2-15 PRESSURE volume relationship of an isolated lung filled A. with air and B. with saline. The saline-filled lung has far greater compliance due to absence of surface tension at water-air interface seen with air-filled lung. Changes in the lung compliance. Decreased compliance. The lungs can be caused by lung diseases, e.g. tuberculosis, silicosis, that produce scarring or fibrosis of the lungs, destruction of the functional lung tissue, or both. Reduced compliance produces a condition termed RLD. Patients with RLD must generate greater than normal forces to expand the lungs. Increased compliance is produced by the pathologic processes that occur in emphysema as well as from the aging process. Alveolar septa, which provides some of the retractive forces in lungs, are destroyed under both conditions, but emphysema causes a much more extensive loss of septa than the normal aging process. Worker breathing. The contraction of respiratory muscles causes the expansion of the thoracic cage and thereby causes expansion of lungs and fall in intra-alveolar pressure and allows the atmospheric pressure to push air into the lungs during inspiration. Thus, to move the air into the lungs, the respiratory muscles have to do work to overcome the following resistances. Resistance to breathing. Tissue resistance. It is the resistance offered by the tissues as they expand or contract. Tissue resistance comprises 1. Elastic resistance. It is the sum of forces of elastic recoil exerted by the lung and the chest wall. The elastic recoil of the lungs is due to the presence of elastic fibers in the lungs and due to the alveolar surface tension. 2. Viscous resistance is the resistance offered by the non-elastic tissues in the lungs. Airway resistance. It is the resistance caused by friction of gas molecules between themselves and the walls of the airways. Factors affecting airway resistance are 1. Rate of gas flow. Greater the rate of gas flow, greater is the resistance. The rate of gas flow is highest in the intermediate-sized bronchi as they have highest cross-sectional area. So the highest resistance to flow occurs in this part of a tracheobronchial tree. 2. Airway radius. It is the most powerful determinant of resistance. Smaller the radius of airway, greater is the resistance. According to Poiseuille-Hagen formula, see page 302. Resistance alpha 1R4. In other words, if radius decreases by half keeping the other factors constant, the resistance increases by 16 times. Airway radius increases when lungs expand during inspiration, and it decreases when lungs contract during expiration. Therefore, airway resistance is high during expiration as compared to inspiration. Because of this reason, in bronchial asthma patients where bronchoconstriction develops, inspiration is possible but there is extreme difficulty in expiration. Control of airway diameter. Sympathetic adrenergic stimulation to the airway causes bronchodilation. In human, direct sympathetic nerve activation causes only slight bronchodilation, because these nerves do not actually innervate the bronchial smooth muscles. However, the bronchial smooth muscles contain a large number of beta-2 receptors that respond to circulating adrenergic substances such as epinephrine, norepinephrine and isoproterenol. Vagus nerve cholinergic. Stimulation causes bronchoconstriction and increase in mucus formation. Cholinergic activity may be the cause of asthma in some individuals. Non-adrenergic non-cholinergic control of bronchial smooth muscle is exerted through following substances. Non-cholinergic excitatory compounds such as substance P and neurokinins A and B cause bronchoconstriction, mucus secretion and increased vascular permeability. These substances may be involved in pathogenesis of asthma in some individuals. Non-adrenergic inhibitory system consists of postganglionic neurons that release vasoactive intestinal polypeptide VIP and other mediators that cause smooth muscle relaxation and inhibit mucus production. 3. Length of airway. It does not change much during respiration or in lung diseases and therefore is not an important factor. 4. Type of airflow. The airway resistance is more in turbulent flow, e.g., during rapid respiration, than in laminar flow or streamline flow in quiet breathing. Components of worker breathing. The total work done by the respiratory muscles during quiet breathing may be divided into following components. Work done to overcome elastic resistance, 65%. Work done to overcome viscous resistance, 7%. And work done to overcome airway resistance, 28%. Calculation of worker breathing. The worker breathing, i.e., the work of inflating the lungs, can be calculated by plotting the change in lung volume, delta V, versus the change in intrapleural pressure, delta P. Fig. 5.2-16. The total area represented by delta P delta V in figure 5.2-16 is proportional to the work that must be performed by the respiratory muscles and to the O2 utilized by them. The work done by the respiratory muscles can be calculated separately for inspiration and expiration. Figure 5.2-16 calculation of work done during breathing by plotting the change in volume, delta V, against change in intrapleural pressure, delta P. A. In normal quiet breathing. B. In restrictive lung disease, RLD. And C. In obstructive lung disease, OLD. Work done during inspiration. In figure 5.2-16a, the area ABC denotes the total work done during normal inspiration. The work of inspiration can be divided into 3 fractions. Compliance work refers to the work done by respiratory muscles to inflate the lungs against the elastic resistance of chest wall and lungs. It is represented by the gray triangular area AYBCA in figure 5.2-16a. Thus, most of the work done, 65%, is used to overcome elastic resistance. Non-elastic resistance work is done to overcome the non-elastic resistance. It includes the work done to overcome viscous resistance of lungs, 7%, and airway resistance, 28%. It is represented by pink area AXBYA in figure. Worker in pain markedly during muscular exercise, physiological. Chapter 5.3. Pulmonary circulation. Functional anatomy. Refers to the work done to overcome airway resistance, calculation, the work of breathing, the work of it, versus Fig. 5. The work done, figure against A. In normal B. In and C. In work done during in figure, the work of it compliance work refers to the work done by respiratory muscles to inflate the lungs against the elastic resistance of chest wall and lungs. It is represented by the gray triangular area AYBCA in figure 5.2-16a. Thus, most of the work done, 65%, is used to overcome elastic resistance. Non-elastic resistance work is done to overcome the non-elastic resistance. It includes the work done to overcome viscous resistance of lungs, 7%, and airway resistance, 28%. It is represented by pink area AXBYA in figure 5.2-16a. Thus, only a small amount, 7%, of the work done is used to overcome the viscosity of the lungs and 28% of the work done is utilized to overcome the resistance of airflow through the respiratory passages. Work done during expiration. Since in quiet breathing, expiration is a passive process, so no work is done during expiration. The gray triangle AYBCA in figure 5.2-16a represents the stored elastic energy that is present at the end of inspiration. This stored energy can compress the alveolar gas and create expiratory flow. When the lungs are recoiling back, some energy is required to overcome non-elastic resistance, i.e., the airway resistance plus viscous tissue resistance. This is represented by the area AYBZA, which in normal quiet expiration falls within the triangle AYBCA, stored energy. And so no extra work is required to overcome this resistance. Worker breathing done in restrictive lung disease. In the presence of RLD, the patient has to overcome significantly higher elastance forces for the normal tidal breathing. So, in RLD, more work has to be performed by the respiratory muscles during inspiration to overcome the decreased compliance. Fig. 5.2-16b. Minimal worker breathing is a function of airway resistance and respiratory system compliance. Fig. 5.2-17a. All species of animals use the combination of tidal volume and respiratory rate that requires the minimal worker breathing. The increase in the elastance work done in patients with RLD can be minimized by breathing rapidly and shallow. Fig. 5.2-17b. The tidal volume is decreased, but the increased respiratory rate ensures adequate ventilation of lungs. Figure 5.2-17d ETERMINANTS of an optimal breathing to do minimal worker breathing. A. Variations in different components of worker breathing. The preferred respiratory rate to do minimal worker breathing normally is 12 to 15 breaths per minute, with tidal volume 0.5 L and B. Total worker breathing curve reflects that the patients with obstructive lung disease, OLD, minimizes their worker breathing by decreasing respiratory rate and increasing tidal volume, and those with restrictive lung disease, RLD, do so by decreasing tidal volume and increasing respiratory rate. Worker breathing done in obstructive lung diseases. In patient with OLD, the airway resistance is increased due to narrowing of passages. The patients must generate increased pressure gradients to produce adequate airflow. So, during inspiration, more work by respiratory muscles is done to overcome the increased non-elastic resistance. As a result, the work loop broadens significantly, as is evident from the pink area AXBYA in Figure 5.2-16C vis-a-vis 5.2-14A. Under such circumstances, when the work loop extends beyond y-axis, active contraction of expiratory muscles is required to accomplish the task of expiration, as the elastic recoil, stored energy represented by gray triangular area, is not sufficient for it. The extra work performed by expiratory muscles is represented by brown area in Figure 5.2-16C. Compensatory mechanism. The resistance work can be minimized by breathing more slowly and deeply, see Fig. 5.2-17b. This prolongs the time of expiration, which reduces the pressure gradient necessary to generate gas flow. The increased tidal volume compensates for the decreased respiratory rate so that normal alveolar ventilation is maintained. Factors affecting total worker breathing. Total worker breathing during quiet respiration under normal circumstances ranges from 0.3 to 0.8 kilograms mountain per minute. Normally, the worker breathing represents 2-3% of the resting O2 consumption. If either the respiratory resistance increases or the compliance decreases, the respiratory work will increase, and therefore the respiratory muscles will use more O2 to overcome the added load. The worker breathing is also increased markedly during muscular exercise. Physiological. Chapter 5.3. Pulmonary circulation. Pulmonary circulation. Functional anatomy. Pulmonary circulation.